telomere length.
Yes.
How expensive is it, the test?
Well, at the moment, it's still a sort of academic test we do. We're doing studies. It's not actually available for patients. It costs about £400. Fish cytogenetics costs about 220. CD38 is a bit cheaper. ZAP70 is a bit cheaper, but it's of that order. And that's part of our argument. We're spending hundreds of thousands of pounds. The 400 quid don't seem much in the big scheme of things, but the NHS has a very poor record of funding prognostics. Is the truth of the matter. They don't like spending money on that. They'd like to say we'll spend it on therapy, but what we've been trying to tell everyone is these things are phenomenally important for the patients and phenomenally important to clinicians in deciding what's the right treatment for the patient. But they don't have a great record of it, is the truth of the matter.
Could you possibly pay for it yourself? Telomere length test?
Not at the moment. We actually have work going on to try and put the business case to NICE. That's the ongoing situation at the moment.
Hello there. My wife's on watch and wait at the moment, but the treatment that's, and she's 17p, p53 deleted, so she's eligible for ibrutinib, and the potential treatment, or the treatment that's being offered, possibly starting soon, would be IR. From what you said, am I right in saying that she can't be on IV because it's not gone right through NICE yet by the end of the year? Is there any reason why that would be IR rather than IV?
First and foremost, you're absolutely right. IV is nowhere near going through NICE yet. In fact, you're not meant to give IR because that hasn't gone through NICE either. I alone is approved for 17p deleted. Ibrutinib, Idela rituximab has been approved for 17p up front. And then you'll have venetoclax. At the moment, you've got the choice of 3 agents that would potentially work in that particular group of patients. But it should be ibrutinib alone. There's no evidence that IR is better than I at the moment. That's one of the questions Flair is asking. In it. So you've got the 3 drugs, which, as I say, work better than anything's ever worked before. So it's I on its own should you need it. We know 17p stage A, on average, some patients can go 3 years before the disease wakes up. So it's different if you've got stage A 17p, and there's reasons behind that. But you usually tell patients 17p stage A, you're going to need treatment within 3 years. And at which point do you actually decide to start the treatment? That's a discussion between the doctor and the patient. And a lot of the patients, it's really quite bizarre, those patients on watch and wait, that when you say you need treatment, it's, oh, thank God for that. At last, something's being done. If you take one step back, you've just volunteered yourself to have something you may not otherwise need. But at least someone is doing something, that at least someone is taking my disease seriously now. And it really is a whole mixed bag of emotions that are going on at any one time. But 17p up front, ibrutinib should do a real treat with it. And you've got Idela and venetoclax. There'll be other things coming along. There may even be CAR-T by the time we get there. A very well-known CLL patient in the States has recently undergone CAR-T, who is in that sort of situation. It is coming. Flog a couple of kids, go to America and have your CAR-T. If you've got kids worth that sort of money, I haven't. Not many people have. Next question.
Hi, my name's Steffi Sashes. I'm a year in, I'm on watch and wait. And my question was about the Orphan Drug Fund, which I found, and I wanted to know how much use was made of it in the UK and from the pharmaceutical companies over here. Because obviously I think what a lot of us want is, if we're on watch and wait, is not just to go on to these sort of quite powerful drugs that you're talking about now. We want an early treatment that comes forward and gets us to a good state. Many of us are not symptomless.
Yeah, so the Orphan Drug Fund hasn't really impacted on CLL. Orphan drugs are for what I regard as rare types of diseases, and CLL falls into the orphan category. but it hasn't really been used in that way. The problem with upfront therapy studies, that for the watching weight, back to that chlorambucil, which didn't do anything, is the drugs you want need to be non-toxic, because you want to get on with your life as best you can, and they've got to be effective. Ibrutinib would fit that model, for example. But ibrutinib at £34,000 per patient, you would need a study going on for probably 10, 15 years to show ibrutinib is better than doing nothing. So unfortunately, you're a neglected part of research at the moment, because the pharma business have decided no one's going to be able to afford that. And they don't want to wait 15 years to do a study to prove that. They want their money now. How much does ibrutinib cost to make? It's probably tuppence halfpenny. It'll be more than that, but it's nowhere near the amount you pay. The amount you pay for all new drugs is largely determined by what the company think they can charge for it, not the cost of the drug. CAR-T, 400,000 per patient. We know in China they can do it for £10,000. So the technology is not expensive, it's expensive is the value of it. So fortunately, you're in that situation where you're probably not going to get what you would like, and what actually is a very reasonable thing to do, because actually no one will be interested in funding it for that long. And usually those sort of studies where pharma are not interested because it's not a market for them, government would fund those sort of things. If ibrutinib costs, say, £5,000 a year, we may be able to have a government-funded study of exactly that. So until the prices come down, I think we're just going to have to suck it up for the time being. Once the price comes down, then the government will fund those sort of studies. They're funding FCR at £26,000 is a one-off. Of course, you get 5 years benefit, 26 divided by 5 is £5,000 per patient. The government are funding that bit. So if the price of these newer novel agents comes down, then we're likely to get round to answering those sort of questions, which, as you rightly point out, is 70% of CLL patients at diagnosis. It's a very, very big unmet clinical need. But most development, unfortunately, is driven by commercial pharma and what's the market out there.
But from what I understand, big pharma charge different prices in every country, and if I was in India, ibrutinib will cost me £5,500.
Yeah, and that's because they're making it for less than £5,500. You're absolutely right. So no doubt they're making a profit on that. Not all companies are like that. Some companies have a global price. It's the same in every country. Other companies, the national company, for example, off the top of my head, GSK UK can charge a different price from GSK Germany. But it's not true of all drugs. But you're absolutely right. Ibrutinib is probably, it would surprise me at all if they could actually produce ibrutinib for £2,000 per patient per year. It's not rocket science once you've actually developed the method. And there's ibrutinib, there's tyribrutinib, there is acalabrutinib. Other companies have already worked out how to make very similar things. So it's not rocket science, but we need the price to come down. We're not allowed to import ibrutinib from India, inside or outside the EU. That's WTO rules. You'll be thrown out of WTO. If we imported it from India and did a UK study with it, unfortunately, we'd be thrown out of that. Is that a bad thing? I mean, we've been thrown out of every other bloody thing in the world. I mean, sod the world, we'll just buy the Indian stuff and do our own study and get thrown out of the WTO. So what? That's me and Nigel Farage, sort of. Sorry.
So, on a sort of slightly related note, just listening to you, it sounds like, venetoclax, rituximab, ibrutinib, fantastic drugs. Logically, it would seem to me anyway, that especially with the history of FCR, that eventually we realised it was worth giving free drugs altogether. Is nobody thinking about doing that and sort of maybe hitting it really hard and obliterating it with all three drugs?
So there is a study at the moment. There's all sorts of studies going on. So the answer is yes. The most advanced one is using FCRI, ibrutinib combined to FCR. Pardon?
Who wants chemo
Well, exactly. This is the thing. FCRI looks even better than FCR, surprise, surprise. But the real drive is to get away from chemo. So in Germany, they got to study venetoclax, ibrutinib, and obinutuzumab. So those studies are going on. The question is who can afford those if they prove to be better. It's a slightly different matter. It's a political matter. But those studies are going on. Yeah. But you're back to that, yeah, you're absolutely right. Those studies are going on. So let's say that FCR is the gold standard now. You need a study like FLAIR for at least 7-8 years to show what's better. So there you are in a country, you're doing, I don't know, IVO, ibrutinib, venetoclax, obinutuzumab versus FCR. You will show that is better, I have no doubt. What's happened in the meantime is the British have published to say actually that IV is better than FCR. So by the time you've completed your study, you're comparing it with FCR, which we now know is not the right comparator. FLAIR is pretty unique around the world. So if you take one step back, all these things are driven by commercial pharma. What Professor Hillman did in Leeds, and I've no idea how he did it, maybe he's got dirt on people, I don't know, is he got companies to agree to go head to head. So what would happen if those drugs are not better than FCR? They have basically killed off their market and lost billions.
Yeah, but not for 10 years. By 10 years they've lost their generics. They haven't lost anything, actually.
Oh no, they wouldn't see life like that. They would not see life like that.
I work in pharma, and trust me, they don't care about 10 years' time. Because in 10 years' time, ibrutinib will be off patent and it will be cheap. So then,
Yeah, but they wouldn't agree to it. Peter's done an amazing job to get what he's got. And out of those regimens, the missing link is actually Roche. So you've got 3 big companies at the moment. There may be more, but the big ones at the moment are Janssen with ibrutinib, AbbVie with venetoclax, and you have Roche with obinutuzumab. FLAIR does not have a Roche product in. To get Janssen and AbbVie to agree to do a study which may show I alone is as good as IV in terms of long-term survival, AbbVie have put an awful lot of faith in that. Now, I think it's well-founded faith, don't get me wrong, but they are taking risks. And they don't normally like taking risks, they like taking money. And therefore, that's why Roche are not part of it. Roche would not join in, because maybe IVO is actually the best thing ever, and that is all you'll need forever, for all we know. But getting these companies to agree to let you have the drugs free is actually a major, major undertaking. And you know, hats off to Peter Hillman. I've no idea how he's done it. Absolutely brilliant. But I do know that some of the companies, I'm not talking about that study, but other studies, they've regretted what they've entered into because their shareholders have said, why the hell are you doing that? So it's a really complicated thing. Unfortunately. If they all cost tuppence halfpenny, we'd have sorted it years ago.
Following up on this lady's question about activities which you can do while you're waiting for treatment, and you're the first consultant I've heard in 6 of these conferences I've been to that's mentioned stop smoking, healthy diet, health, fit. I'm sure that would take a 10-year study to get approved as well. But are there any studies, could we not have something that suggests that? If I recall, my memory is not that good, but I do have notes on it at home on my computer, that in Alberta, Canada, they've done yoga and Tai Chi with telemeters lengthening from the resulting of those physical activities. Yeah. There are other tests as well.
There are lots. One of the things for CLL is immunity, infection, and well-being. There is no doubt people who are depressed, their immune system goes down. People who are malnourished, their immune system goes down. There are markers you can use that actually show benefit from that. And I'll give you a personal anecdote. Not so much CLL, it's slightly different, but other cancers I deal with where life expectancy, you're either cured or you're not. You can't live with it. No one survives who doesn't want to fight. The therapy alone cannot make people who've given up cured. It just doesn't work like that. That inner well-being, and there are markers you can show of improved immune responses, Whether in the lab showing improved immune response equals you actually do better, those are the ones you need the long-term studies for. But you're absolutely right, and it's something we've talked about with leukemia care last week actually, of what studies can you do for that watch and wait group, which actually realistically we can do. Vaccination is one possible one, healthy living is another. Is to say, when I look at my pure postcodes in Cardiff, and you put certain postcodes in which equals socio-economic, the same service, they don't do as well. It'd be pretty straightforward. It's a study to do that. What do you do about that? So if you've got someone in a socio-economic poorer area, do you give them better food? Do you give them a gym membership? Or do you give them money so they can buy more cigarettes and drink more alcohol? How you resolve that social thing? But it's a very, very big player in outcome for patients. And that's why it's great to be here, because the battle against CLL does not start the day you start your chemo. It starts the day you have your diagnosis, because what you do and how you do it matters enormously. And some very simple questions like the best way to vaccinate, which vaccinations, how often, do you need repeats? We have no idea. No one's done those sort of studies to the degree we need them doing.
Good morning. I'd like to know, can you tell me which country does the best diagnosis work?
Oh, good God. Well, it's very interesting. We're beginning to see real-world experience of drugs coming out, etc. And there was a lovely paper from America last year that showed that if you're in America and you got treated in a university-type hospital, you did best. If you got treated by the community physician who does CLL in America, half of them didn't even have a P53 test. Half of them got treated by rituximab alone. So even in the wealthiest country in the world with the very best healthcare, it's only there if you can afford it and you're in the right place. Otherwise, you're getting some of the worst care. And if I was treating patients without knowing the P53 status, you could probably get sued for that, handing out FCR without doing the test. In America, in these socioeconomic poor areas, that's the norm. That is the standard. If you're asking where's the best place in the world to get CLL, the answer is there is nowhere good to get CLL. Where would I want to be treated? Outside Wales, of course. Definitely outside Wales. I don't know. If you've got a competent physician who knows what they're doing, it probably doesn't matter. It's all about the competency of your physician. And again, a lot of patients leave the doctor not really understanding, go away and worry. Do not leave the doctor, do not stop pestering until you really understand, and go back to them time and time again if you have to. So I don't think it matters. We've now got the treatments. Most of them are now NICE approved. We've got to work out how best to use them. I don't think it really matters. Your quality of life, your survival depends on you and your doctor at the end of the day.
Thank you very much. I'm sorry to put you on the spot.
There's no point in coming to me. I'm retiring in 2.5 years. You'll have to do your 20 years without me, so you may as well find a doctor now who's going to be with you 20 years. Oh, sorry, yeah. This is another orphan drug one. It may come. How many in the programme at present that may come forward? Why so few details on this? And are Cardiff involved in this programme? There are always new drug developments. It was quite interesting going to America in December to the American Society of Haematology meeting. You hear about all the new drugs, etc. They had a bit of that, but CAR-T is what was all about. So Big Pharma is looking at immunotherapies as the way of keeping their profit margins up. You know, 3 of the 10 biggest companies in the world are pharma companies. So producing drugs is not necessarily a good way of making money. The other problem with CLL, if you're a pharma company and you have got a drug, do you try and break into the CLL market with venetoclax, ibrutinib, obinutuzumab, or do you go for a disease where there are no effective treatments? So we're already beginning to see that actually they're not starting the trials in CLL. Big Pharma thinks they'll not get enough share of the market, or maybe even it's a problem solved. in which case there is no market for them with the things we've already got. So getting these studies into CLL is not easy. We do what's called first-in-man studies in Cardiff. These tends to be for any hematological malignancy in reality, and you can put CLL patients in this, and the first CLL patient in that study was in one of those studies. I've treated an AML, a low-grade lymphoma, an acute leukemia, a high-grade lymphoma. Now at last they've let me do a CLL patient because actually they're more interested in the other diseases. So they are coming through, but I don't think they're putting the resources into it, particularly with CLL in mind anymore. There's other lymphoid malignancies, follicular lymphoma, high-grade lymphoma, acute lymphoblastic leukemia. They tend to be concentrating on that, which in some ways is it's a positive message, but in another way, until we're curing everyone with a minimal amount of interruption to their lives. If your first treatment is ibrutinib rituximab, what are your treatment options? That's a very, very good question. Because this is one of the things, if we completely change the paradigm for you start with FCR and then you go through the rest, what happens if we can show that these new agents should be used up front? What happens when they fail? Well, the simple answer, ibrutinib rituximab, you've still got idelalisib, that may still work. You've still got venetoclax, that may still work. Actually, chemotherapy will probably still work. And I've had a patient who had bendamustine rituximab 5 years ago, relapsed, had a thing called tyrobrutinib in a study that worked for 3 years, stopped. I gave him idelalisib, he didn't like that. I gave him venetoclax, he didn't like that, he's a bit sensitive, God bless him. I've just given him FCR and his disease is dissolved away. So it probably, if we follow this logic through, we'll be starting with these new drugs and maybe finishing with chemotherapy down the line. So the answer is there's lots and lots of choices to that, and there's always clinical trials. But ibrutinib rituximab may be all you need forever. Ibrutinib alone, as I say, 5 years, treatment naive, 93% at 5 years. So if you're hoping to live for 150 years, you will need something else. If you're hoping to live for 5 years, you've got a 93% chance you've already got the answer. Husband is 17p deleted 11q. Idelalisib rituximab failed at 4 months. Now cycle 5 venetoclax rituximab. What are your views on length of venetoclax maintenance after completing rituximab? That's a difficult thing. Certainly no less than 2 years. One of the discussions is 2 years the right thing, or should you be using minimal residual disease? And maybe the argument is one, if you get VR and your disease has disappeared in 6 months, maybe you don't need 2 years. If you get VR and it takes 20 months to eradicate your disease, maybe 24 months is too little. So should we be using minimal residual disease as a measure of how sensitive your disease is, your particular disease is, to that treatment? And then maybe if it takes 20 months, you need 40 months of treatment to really give it a hiding. If it takes 6 months, you only need 12 months. There are studies going on trying to answer that question. Of course, drug companies where design studies want you to use it forever, because then you're paying them forever. So that question of do you need it forever is now beginning to be answered. First of all, does it work? Yes, it does. If so, how long do you need it for? But most of the new studies say you need it forever. But probably you don't. But how do we do that? After relapse, 6 years after FCR, what is the optimum stage to start ibrutinib? And this is a difficult one. If you look at the guidelines, indication to treatment, fall in hemoglobin, fall in platelet count, growing lymph nodes, growing liver and spleen, fatigue. Some patients, once the disease starts to wake up, it's really beginning to bite on the patient within 3-4 months. Other patients relapse much slower. Most virtual patients need treatment within 2 years. Again, you're the patient, you tell the doctor when you think you need treatment, and in your head you think, well actually, I'm not happy with my quality of life as it is today. I want to be able to do more. I want my disease treated. And that threshold will be very different for people. Hands up if you look after the grandchildren. Yeah, see, this is the generation we're in now. You know, Some people, they want to be healthy into late life because they want to travel the world and make up for all the hard work. That ain't going to happen. You've got the grandkids. You want to be well enough to look after the grandkids. You will never, ever be well enough to cope with the little things, little darlings. But if you've got things you need to do as opposed to you want to do, your threshold for wanting treatment and what sort of treatment is very different. And that's why relationship with your consultant is just so important. There's no right answer. I have patients who I'm telling them, I think you should have treatment. I feel okay, I can do what I want. No, but if you look at where you were 2 years, I'm still happy where I am. They leave it too long. Nobody wants to go too soon. Nobody wants to leave it too long. I had one recently who declined treatment completely because they had to look after the grandchildren. And this is previously untreated. I had to sit them down and say, you won't be here in a year to look after the bloody grandchildren. And then what happens? The grandchild says to their mother, your daughter, mummy, 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 why did Granny let herself die? Did she not love me? If that's why she killed herself. I won't say the expletive she said to me when I said that to her, but I was a bit taken aback, and I'm of Irish stock, I'm used to certain language. I was a bit shocked, but she called me something. And I said, but that's the reality, you need treatment. You're no use to your grandchildren if you're not here. So tell the parents they've got to sort it out for the next 6 months while you get yourself better. When you're better, you can go back to that. It is very different for everyone. So the answer is, it's when you feel you need treatment. And that's a discussion with your doctor. What do you mean by mutated? So genes which are abnormal are called mutated. So P53 can be mutated, 11q can be mutated, etc. By mutated in this, we're talking about your B lymphocytes' normal job is to produce antibodies. When you get exposed to antigens, they're called your B lymphocyte rearranges its immunoglobulin genes, and we call that mutated immunoglobulin genes. 30% of CLL patients have unmutated. They behave like they've not seen an antigen before, and the other 2/3 behave like they have. And so the mutated are the better prognostic group, CLL. But a lot of places do not routinely do mutation status like this. We don't do it in Cardiff. We do it as a research tool because the NHS wouldn't pay for it. So some of you will have had it done and some of you won't. And it's one of the most important because it tells you at the very beginning what group you're likely to be in. So ask your doctor if they ever done it. One of the good things of going into a trial is you usually get it done. I've been on watch and wait for 6 years, only significant deterioration has been fatigue. I saw on patient power video recently that the consultant had some success reducing fatigue with a mild dose of one of the new drugs. Have you heard of this, please? Yeah, 2 things about that. The commonest reason for treatment in America of any sort is fatigue. That is not the commonest in Europe or Britain. In America, you come along and they say, I feel really tired, doctor. Of course you do, of course you do. You've got leukemia, you know. Anything you can do about that? I've got some tablets I can get. Oh, cheers, doc, wonderful. Half the patients I treat for fatigue alone, it makes absolutely no difference to them. Half of them do benefit. And a real difficult patient group, minimal disease, very little disease at all, but the patient tells you they're shattered. And that's a very different clinical problem. There's no test to know whether that's for CLL or is those bloody grandchildren grinding you down, it is those children, it is your daughter's divorce, it is you're depressed or whatever. It's always the fatigue is very difficult. Of course in America I say yes. I hear the ka-ching of the till. Every time I give you treatment, I'm tens of thousands of pounds better off. You've got leukemia, I've got a treatment, win-win, ka-ching. In Europe it's not quite like that. Fatigue is one of these most difficult things for patients and physicians. And quite often you only know when you've given the treatment and just the patient get better. And because CLL creeps upon you, a lot of people don't even realise they're fatigued. Then you give them the treatment and say, good God, I felt like I did 10 years ago. Because actually their disease had a bigger hold on them than even they realised, or even I realised. So fatigue is a very difficult problem. As for low dose of the new agent, I don't think anyone would recommend low dose. The dose has been fixed at what was the effective dose. If you take antibiotics and you take low dose, what you're doing is encouraging resistance. There's no proof of that with the new agents. You would encourage resistance, but intuitively, that's what you think you may be doing. So I'm not sure that is something a lot of people would recommend. But if it works, excellent. But why did the fatigue get better? Is that because the doctor's doing something active for you? It may not be the drug at all. They could have given you placebo and you may have got the same effect. It's the power of the mind. And there's been some fabulous studies recently about the powers of the mind, not related to CLL, but other things. What's the potential for CAR-NK therapy in CLL? Very good question. Lower costs off the shelf. It's unproven. It's the truth. Some people look at natural killer cells because you don't have to bother. You can get them off the shelf and use somebody else's natural killer cells. They won't react to you and vice versa. Early days, I think, is the honest answer to that. If true CAR-T can be made for 10K, we won't need CAR-NK. So it's going on. If you remember as well, now the big companies have bought these expensive therapies. If you come along, Chris Fegan, PLC from his shed in Cardiff, produces CAR-NK for a bit of the price, they're not going to allow me to do that. They've invested billions in making sure their product works. So it won't be easy if you come along with something cheap. Chris Fegan comes along, it's 10,000, all they'll do is come along and drop their price to 5,000, see you out the market and up their price again. Can I request venetoclax? Your access to venetoclax is 17p or failure of ibrutinib Idela. That's the NICE approved indication. So you can't request it. We can request it outside that. Your clinician can do an independent patient referral, funding referral, an IPFR, sorry, individual patient funding request. You may or may not get it funded. So by all means ask. But as I keep telling the wife, remember, if the answer is not what you like, there is disappointment if you ask unreasonably. So by all means ask, but don't put your hopes on it. Are patients likely to get such good treatment in all CLL patients? This is a very common question. It depends what you mean by treatment. Anyone can hand out FCR. You follow a recipe. It tells you what to do. The skill in managing FCR is experience, your communication with the patient, and understanding the situation. So it depends what you mean by good. The treatment's good. Everyone will get FCR. Whether you stand maximally to benefit from that is about you and your relationship with your hospital and your consultant, the day, you know, ease of access through A&E, etc., etc., etc. On paper, of course, it's all equal, and of course, it's all good. I'll move on. I was told I got CLL because of my treatment for breast cancer 18 years ago. Is that true? That's absolutely incorrect. There is no evidence that any previous treatment causes CLL. We actually don't know what causes CLL. The theory with CLL, remember it's a cell, its job is to cause antibodies. That's its job. We think it's probably an infection, chronic infection. Your body is reacting to that. You then get the genetic abnormality, and then you get leukemia. In CLL, we haven't proven that, but in lymphomas, which are related, same B lymphocyte, but different things, we know there are viruses that can do it. If you treat the virus, the lymphoma goes away. We know there's bacteria that can do it. If you treat the bacteria, the lymphoma goes away. You don't need chemotherapy, you give them antibiotics. We think CLL is the same. And if you look at CLL, back to the clever things we can do, they look like they're reacting either to an infection, or you've heard of rheumatoid arthritis. That's where your own body reacts to itself. Half the patients in CLL look like they're reacting to an infection. The other half look like it's an autoimmune disease, like rheumatoid arthritis. Your CLL is reacting to you, what's called an autoantibody, and then eventually a genetic abnormality hits, and then it becomes malignant. But we don't actually know. Certainly nothing to do with the breast cancer therapy. I can reassure you of that. Is there any suggestion to help improve your immune system to help repeated viral infections? It is very, very difficult. Some patients are more prone to others. Viral infections tend to be the sort of herpetic type things, the things we carry on us and live with normally. The immune system drops down. Herpes shingles once, long-term acyclovir. Herpetic infections, acyclovir. If your antibodies are low, you need intravenous immunoglobulin. Very few patients, in my experience, have ongoing chronic problems that acyclovir and antibodies can't actually sort out. So if you are getting that problem, do speak to your doctor about that and just make sure that the maximum things have been done. There will no doubt be individuals where those won't be enough, and you may unfortunately be one of those. And of course, depending on what sort of infection it is, what sort of people you're coming into contact with. And sometimes you get trigger for viral infections. It will flare up when you get a bacterial infection. So if you get a bacterial infection, you're not an antiviral, make sure you ask for those as well at the same time. And then somebody very keen. Last question, 2 in 1. After 6 days of FCR medication, the infusion of 5 days, how long do those chemicals stay in the system, and what is happening between days 7 and 28? Fludarabine, you give fludarabine intravenously, it's actually out of your blood in 15 minutes and into the cells. So it's a bit of a misleading question in the sense, how long is it in you? It's in your blood for 15 minutes, fludarabine. The effect of fludarabine takes about a fortnight. So the drug is all gone, but what it's done is trigger off a cascade of events that you're still living with. So the drug ain't there, but the effects of the drug is. Rituximab hangs around for probably 2-3 weeks. So that is actually still circulating in you with FCR. Likewise, cyclophosphamide, only a few hours and the drug is gone. So what you're living with is not the drug going around you. And people say to me, yeah, I got to day 5 afterwards, thank God I've now washed the drug out. No, you washed it out that same day. The effect of it is still there. You're healing up. And back to chemotherapy is killing dividing cells, the neutrophils, the lining of the gut, etc. You know, it's doing it whether you get nausea, vomiting or diarrhea. You're getting damage to those fast-growing tissues. Normal bowel takes 7 to 10 days to recover. That's how long, that's what determines the duration of the toxicity, is what's the recovery rate of the normal mucosa of the bowel, sperm production. So sperm production gets killed off by FCR or reduced by FCR, probably 3-4 days later, you're as fertile as you were before. So yeah, you need to be careful. You can't assume your FCR is keeping you and your loved one away from having kids. That may not be the case with those fast recovery tissues. In reality, most people with FCR, probably men, are infertile at the end of it. There's, again, not been much work on that. So if you do want kids going forward, God knows why you would, but maybe you do. Remember to talk to your doctor about sperm storage early on if you're a fella. My brother had a kid at 52 by choice. Quite nuts. Well, she's now 18 and he's 70. You can imagine what sort of relationship that is. And it was a girl. Wrap round the little finger. Too bloody right. Daddy, 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 when you die, you are going to leave all the money to me, aren't you? Yeah, wonderful. During the time our FCR are still doing their magic, as I say, the effects of them carry on. The reason why it's every 4 weeks is simply, back to those early studies, the first person, whoever gets these drugs, it's on them you're determining when is it safe to give the next lot. And with FCR, 3 weeks was deemed to be too soon. It's no more scientific than that. The body hadn't quite healed up enough. In high-grade lymphoma, CHOP chemotherapy, which has been around since 1972, was initially given every 4 weeks, then every 3 weeks. Now we're much better at dealing with the consequence of it. We can give it every 2 weeks. But FCR every 4 weeks seemed to work pretty well in the studies. But it doesn't mean you couldn't maybe have it every 3 weeks. We'd expect more toxicity and more problems. So ideally you want the patient to heal up in between, but it is a bit like that. And of course you used, quite often there's animal studies being done before, how long did it take the animals to recover from those doses? That when you start your study, you're basing it on the animal data, and the animal can only tolerate every 4 weeks, so you start with every 6 weeks in humans and try and bring it down to the minimum. Medications for nausea, lots of different choices. The most effective, certainly on Dancitron, before we had on Dancitron, Maxilon, cyclazine, worked to a bit. On Dancitron sort of changed things and made it a lot better. On Dancitron has side effects of its own, constipation, etc., etc. It's ring the changes. There's now, again, I probably shouldn't tell you, there's cannabis-type drugs for nausea available. There's injections for nausea. If what you're given doesn't work, you insist on having something stronger, because there are lots and lots of very good antiemetics now. And I've got a very odd patient who needs an injection before they get. It's very unusual, but it seems that FCR is not regarded as a really nauseating inducing regimen compared to the sort of things we hand out in other diseases, and therefore quite often you start with the minimum. That doesn't mean the minimum is all you can have. You can have much more powerful anti-sickness ones, and again you want to get the one that gives you the relief you need without the side effects of it. So again, speak to your doctor. Most of my patients don't need any antiemetics at all, and I've got some of them who've needed the full toolbox of antiemetics to get them through the treatment. But most of them don't need anything, is reality. If you're one of those unfortunate people where it does affect you, then speak to them and get something better, because there are better things there. I hope the day goes well is what this person has written at the bottom, and I would concur with that, and I think it is lunchtime, isn't it?